Comprehensive, relevant, and insightful conversations about health and medicine happen here on MedStar Health DocTalk. Central to the human anatomy is a fist-sized muscle that is responsible for pumping oxygenated blood throughout the entire body, continuously. Of course, I'm talking about the heart, which for more than 6 million Americans struggles to keep up with the workload. That chronic condition is known as heart failure. 10% of heart failure patients progress to advanced heart failure. We're going to learn more about advanced heart failure today by talking with Dr. Erika Feller, an advanced heart failure and transplantation cardiologist at MedStar Health. I'm your host, Deborah Schindler. Thank you for being here, Dr. Feller.
Thank you so much. Good to be here.
When I hear the term heart failure, it sounds as if the heart is already not working. Is advanced heart failure different?
Yeah, good question. So I think it's interesting. I think the term heart failure probably isn't really the right term to use. So we talk about heart failure, which is really the syndrome of what people get when they have either weak hearts or hearts that aren't working to pump the blood out kind of fast enough or well enough. So that syndrome are things like fatigue, shortness of breath. Many patients get swelling in their legs that you can often see. Some of them get bloating. So that's the syndrome of too much fluid, which is many times called heart failure.
Is it interchangeably used with congestive heart failure? If not, what's the difference?
It is. So congestive is the part that really pertains to the extra fluid. And many times these patients have weak hearts, and so the pump isn't working. So the pump, which is the heart, isn't pumping the blood well enough, fast enough, strong enough to the body. But it can also be in patients that have that their heart works well, it squeezes well, but it doesn't relax well. And that's another type of heart failure, although the symptoms are similar. That's something called heart failure with preserved ejection fraction. You might hear it called HFpEF for short, versus the other kind, which is HFrEF, or heart failure with reduced ejection fraction. Both many times have the same symptoms, though.
Which are what? What would be the symptoms?
A lot of fatigue, swelling, sometimes blood pressures are low, sometimes heart rates are high, bloating, trouble sleeping because of fluid in the chest. You might hear that termed pulmonary edema. So those are the symptoms of congestive heart failure or heart failure, same thing, that many times come with either HFrEF, the reduced ejection fraction, or HFpEF, heart failure with preserved ejection fraction, or the problem with relaxation of the heart muscle.
So that's HFpEF.
That's correct.
What do you mean exactly when you say a relaxed state?
So true. So the HFpEF is a problem with, it can be caused by a couple different things or many different things. But to boil it down, it's when the squeeze is okay. So the heart squeezes the blood out of the heart to the body, but the relaxation part, which allows the blood to fill into the heart, doesn't work as well. And so the result of that is fluid buildup, the fluid part of the blood build up in organs, into your liver, into your kidneys, into your lungs. And many times then that extra fluid leaks out to the tissues or the skin where you can see swelling, a lot of times in the ankles and in the feet and the legs.
Now, people who have those conditions, are they dealing with that like all the time, or is it episodic?
It can really be both. So when people have HFpEF or HFrEF, or heart failure, just to keep it short, they're sort of constantly on the lookout for those symptoms, but they're treatable. And we use medications, they're called diuretics, which really make you urinate the fluid off to keep stable and to keep symptoms at bay. And so that's one of the cornerstones of the symptomatic treatment for heart failure. And so we can use those. Many times they're called diuretics. There's Lasix, there's Bumix, there's torsemide. There are a couple different ones we use to help the symptoms of heart failure. So to keep the fluid off. But then what we really strive to do is to treat the underlying problem that causes the fluid buildup in the first place. And that's to treat the problem of systolic heart failure, or the HFrEF, or the diastolic heart failure, the HFpEF. And so we use a lot of different methods and means to treat the underlying condition.
Who's the typical patient?
You know, the heart failure and the cardiomyopathy, which is really the problem with the heart, can really hit any type of person, gender, age. Generally, it's a disease or syndrome of older people. The prevalence increases as you age, but there are familial cardiomyopathies that are genetic in origin. There are cardiomyopathies that are based on having high blood pressure or coronary artery disease or diabetes or substance use. I mean, those are all markers of what can cause a cardiomyopathy. And so it really can hit any age at any time.
Just for clarification, what is cardiomyopathy? So
cardiomyopathy is an abnormality of your heart muscle. And It's a general term we use to describe the underlying condition that causes the congestive heart failure. We try to find why a patient or a person has a cardiomyopathy or a heart problem. And then we then term cardiomyopathy, we describe it and label it so everyone understands what the problem is. So it may be an ischemic cardiomyopathy, which is a problem with the coronary arteries. It may be a non-ischemic cardiomyopathy, which is just a more general term saying it's not from the coronary arteries. It may be dilated cardiomyopathy, which means that the heart muscle has dilated and gotten bigger. It might be a restrictive cardiomyopathy, which means that the blood doesn't fill the heart as well. So it's a descriptive term to label what the problem is.
Now, are all the treatments going to be different for everything that you just described there? Or do you basically start with the Lasix or the diuretics?
Many times to help the symptoms, we start with Lasix, but we really treat the underlying problem at the same time. So we use medications, and usually they're various medications from different families of medications that help treat the underlying problem, which is the cardiomyopathy. So we know when people get sick or they first develop a cardiomyopathy, their body is kind of saying, there's a problem with the main engine running here. And all of these chemicals and hormones and things like that get upregulated to try to maintain the cardiac output, maintain the blood flow to your other organs. And in the short run, that might work well. Your heart rate goes up, your blood pressure may go up or down, and you retain salt and things like that to try to improve the blood flow to the organs. In the long run, that's not a good thing, and you start to get sicker when that happens. So these classes of medications are aimed at preventing those hormones and chemicals and things like that from going, keep going high in the bloodstream without getting treated. So we introduce those medications sort of one by one, step by step, to try to reverse that whole sort of cycle that your body starts when you first develop heart failure.
What are some of the most common risk factors for heart failure or cardiomyopathy, and are they going to be the same?
So the most common ones are what's common sort of in our societies right now. So high blood pressure, diabetes, high salt diets, coronary artery disease, atherosclerosis, same thing as coronary artery disease. Family histories are important. Those are really the most common. We know now there are other things as well. I mean, there are environmental factors, there are chemotoxic agents, there's things like Lyme disease, there are things like inherited genetic mutations that can run in families. There's sleep apnea, which we're finding is more common than we did, 10, 15 years ago to cause weak hearts. When someone presents with symptoms of heart failure, we start a pretty thorough investigation to try to understand not only what their risks are for developing a cardiomyopathy, but also how to treat the specific problem with that person.
I need to pause a minute because I have to ask about that sleep apnea. I've heard forever that sleep apnea is bad for the heart, but I never really understood why. How does waking up or having a disruptive sleep impact your heart health?
So sleep apnea is not just disrupted sleep, but it's a condition where when the person thinks they're asleep and they're asleep, but they're not getting enough oxygen while they're sleeping.
Okay.
And so for periods of time, and sometimes that can be hours, they're not getting enough oxygen. And so their blood oxygen decreases and they get something called apnea, which means they sort of stop breathing to try to reset.
Okay.
And so when the oxygen level in the blood goes down, then the oxygen to all the organs goes down, and hearts don't like not having oxygenated blood. And many times they can develop, they can get weak as a result of that. They can get hypertensive as a result of that. They can get thicker as a result of that. The heart muscle can get thicker. And so all of those things can develop into weaker hearts over time. Many patients with sleep apnea develop heart rhythm problems that in and of itself can develop a weak heart. So it's a problem that we know more and more about now than we did years ago. It's very treatable. And I've certainly seen heart function return to normal when sleep apnea is well treated.
Because of maybe a CPAP? Now that makes sense to me.
That's exactly right.
Wow, that makes it clear to me now. So I'm not sure if we should talk about ejection fraction first or how to diagnose heart failure. Is it the chicken and the egg, really?
Yeah, a little bit. I mean, so when we see patients for the first time, or we get called to the emergency room, or we see a patient in the clinic, and they're complaining of maybe things that we would think about congestive heart failure, shortness of breath, primarily something called dyspnea, which means you get short of breath when you try to do any activity or walking upstairs. And something that's even a little bit more specific to congestive heart failure is something called orthopnea, which means you lie down to go to sleep and you feel really short of breath when you lie down to go to sleep. Or something called paroxysmal nocturnal dyspnea, which is also something more specific to heart failure, which means you're asleep at night and you kind of jump up and can't catch your breath, and the textbook is you like run to an open window to try to gasp and get your breath in from the cold air from the outside. And that's really specific for something called pulmonary edema. And when patients have some of those symptoms with fatigue and swelling and bloating, and their physical exam is consistent with that, one of the first things we do, which is part of the sort of guideline therapy and diagnosis for heart failure, is a really good physical exam, looking at sort of everything. Blood work that can tell you a little bit about not only their fluid balance, but how their organs are working. An EKG, so you can see what their electrical rhythm is, see if there's anything that may be promoting their heart disease. And then one of the first steps is to do something called an echo, which is really an ultrasound of the heart. And that tells us a lot of things. It tells us what the ejection fraction is, or the squeeze, how well their ventricle, the main pumping chamber of their heart, is squeezing. It tells us what the right side of their heart looks like. It tells us what their valves look like, which could be a cause of heart failure or cardiomyopathy. It can help tell us what the fluid balance is, what the pressures are in the chambers of the heart. So it's a really good way not just to diagnose a cardiomyopathy, but also to follow it over time and to see how your heart may change with medical and other therapies.
Are all of those tests that you just identified necessary to evaluate the ejection fraction?
Well, the echo itself is what determines the ejection fraction. The other tests tell us also a little bit about maybe why there is a heart problem, how to target the heart problem, and points us into a direction of what may be causing the heart problem.
Can you explain the different stages of heart failure?
So clinicians and also providers and patients commonly present at different points of time within their heart failure diagnosis. And we also follow them over time. And it's a kind of disease that can be chronic and many times is chronic that we follow over, weeks to months to years to decades. And the stages of heart failure help us clinicians and talking to patients, understand where they are in the continuum of heart failure, and which is really a continuum. So there are 4 basic stages of heart failure, and there's stage 1, stage 2, stage 3, and stage 4. And the heart failure is worse the higher the stage is. Stage 4 being the worst, which are patients that are really on specialized medications. Many of them have specialized device therapies like defibrillators and things like that, and are being evaluated potentially for advanced therapies like heart transplant and heart pumps. Stage 3 are patients that have symptoms of heart failure most of the time, and they can't do a lot of exercise or activity without getting short of breath or symptoms. Stage 2 are patients that are not quite as symptomatic as that. So they have some symptoms, but they can do a fair amount of activity before they get symptoms. And most of them are at home and monitoring their heart failure. And stage 1 are patients that are at higher risk of developing heart failure, but don't have symptoms. And so that's how we discuss patients among multidisciplinary teams. That's how we evaluate indications for different therapies for patients, sort of based on the level of symptoms and disease states.
Does that relate to new guidelines by the AHA or the American Heart Association?
It does. It does. So it's common to use those stages of heart failure to look at medication therapies, device therapies, when to refer to advanced heart failure specialists based on the stage of patients.
So let's talk about that. What is the process? You go to your primary care physician. They may do some general evaluations, and then they send you to a cardiologist. When does the patient see you?
That's correct. So there's any number of ways that I think a patient would get referred, evaluated, discussed for advanced heart failure or to see an advanced heart failure specialist. So sometimes it's directly from the primary care. So the primary care sees the patient. You've got some risk factors for heart disease. Oh, I might do some of the evaluation. Oh, you have a significant heart disease problem with a cardiomyopathy and heart failure. Many times that primary care can directly refer to an advanced heart failure specialist. Many times, though, also that referral will be from a general cardiologist or even an interventional cardiologist, someone who puts stents in and evaluates the coronary arteries of patients. Sometimes it's from a cardiothoracic surgeon who maybe just did bypass surgery on a patient or did a valve surgery on a patient, and the ejection fraction is low, and they want to make sure that the patient gets all the devices and medications for advanced heart failure. But it's really when patients are starting to either develop complex symptoms and problems that are associated with their heart disease. So they may have a lot of admissions to the hospital for heart failure, or they have a lot of valve disease, or they have complex valve disease that can't be easily surgically treated, or they have arrhythmias, atrial fibrillation or flutter, or ventricular tachycardia, or they have very low ejection fractions, or they have a lot of symptoms despite all the medications. Those are generally the type of patients who get referred to advanced heart failure cardiologist.
What would be the next step after that? Surgery, some kind of procedure?
It might be. We do further evaluations to determine what's modifiable. What may not be modifiable is the patient's prognosis guarded, meaning are they getting sicker despite all these medications? And are we running out of medication options? I mean, that's some of the first things we look at. And we do that by something called what we sort of generally term a prognostic evaluation. And this is to understand how sick is that heart. Is there something we can change? Is there a medication we can change? Or is this patient really having progressive, significant disease? And the sort of two evaluations we do for that is something called a right heart cath or Swan-Ganz catheter. And what's involved in that is a catheter with a little pressure sensor on the end of it that gets inserted into one of the veins that gets thread into the chambers of the heart. And in that way, that little pressure sensor can tell us what the filling pressures are inside the heart muscle. And this tells us really how much what the fluid balance is. So sometimes we've just, underestimated how much extra fluid the patient has. And it's a fairly easy trick to just increase the diuretic, the Lasix, and patients do better and feel better. Sometimes that's a lot more complex and challenging. So it's not just a fluid problem, but the lung pressures are high or the cardiac output, the blood getting out of the heart with every beat is really low. And it's compromising the other organs. So patients can develop kidney dysfunction and liver dysfunction, and they have memory loss, and that's all from just a low cardiac output. We do that test to help guide our next steps in therapy. And we also do something called a VO2 test. And this is a kind of stress test that helps us determine in patients that are fatigued a lot or can't do the type of activity they'd like to do. Why is that? Is it their lungs aren't working so well, they can't get enough oxygen, they're just deconditioned and out of shape? Or is their heart and the function and the cardiac output preventing the blood to get to the muscles to allow them to exercise? And those two basic things, there are other things we do as well, but those two basic things help us determine the long-term prognosis of patients with heart failure.
Now, the VO2 test, that's done with a treadmill?
It is, or a bike, or a stationary bike, yeah.
The other test is in a cath lab?
It's done in a cath lab, correct.
Okay, so they're under a twilight or?
They're under a twilight. The procedure takes about 15-20 minutes. It's not a long procedure. It gives us some really important information. The catheter is thread through the vein, not the artery, but it is a procedure in sort of a cath lab procedure type room.
Is there any point in the progression of heart failure to advanced heart failure that it can be fixed or reversed rather than just managed?
It absolutely can. It depends, though, on what may be driving the heart failure to advanced heart failure. So sometimes it's things like we just spoke about, sleep apnea. So sometimes patient develops sleep apnea, we treat it. They certainly can get a whole lot better and go sort of back to the heart failure, realm where they're not requiring really advanced therapies. Sometimes it's just medication adjustment. Sometimes it's atrial flutter or fibrillation adjustment and treatment of that. Sometimes it's weight loss. Sometimes it's better diabetes control or high blood pressure control, or sometimes it's bypass surgery. So many times we can improve the prognosis of a patient based on interventions.
So if it goes in the other direction, let's say it's not getting better, it can't be repaired, corrected, what happens when medications can no longer control heart failure? What are the advanced surgical options?
So when we talk about advanced therapies, that's sort of a general term, which generally means things like heart transplant, LVADs, left ventricular assist devices. It also means inotropic therapy, which is a medication therapy, but it's intravenous. So it's a 24/7, 365 intravenous medication that patients are at home with.
An infusion?
For the most part, it's an infusion. It goes through something called a PICC line, which is a central line. That's a more permanent type of line. And patients are home with that with a much smaller little pump that they can wear around their waist or kind of carry in a purse type device that pumps continuous medication into their body through one of these more permanent IV lines. And there are two types. It's called dobutamine or milrinone. We probably most commonly use milrinone. And
what does it do?
It helps the heart squeeze. So it doesn't necessarily so much change the ejection fraction. You may not notice a change on a cardiac ultrasound, but it improves the squeeze to get more blood out with every beat. And so in that way, patients many times feel better. They have a little more energy. They may not fill up with fluid or get congested quite so quickly. So you might ask, why doesn't everyone have that? And the reason is because it doesn't prolong life, okay? So it doesn't improve your prognosis. It allows us to have a bridge to more permanent therapies. So we would call the inotropes, these medications, a bridge to be evaluated for things like heart transplant or left ventricular assist device. But it's sort of included in the sort of term of advanced therapies.
Explain what the LVAD is. Now, you mentioned it, but help me understand what that is.
So the LVAD, and you might also hear it called mechanical heart, is an implantable device. So this is a big surgery. It's a surgical implant of a pump that it's about the size, I would say, maybe a little bit smaller than a box of cigarettes. And it sits inside the chest, and it takes blood from the left ventricle through a little tube, and it pumps it back to the main artery of the heart, to the aorta. And it's powered by batteries or an electrical wall socket through a controller, which is a kind of a computer part that the patient wears. And there's something called a drive line, which connects the pump to the power source and the controller. And that part is inside the chest, but then actually exits in the abdominal area. And that area, over time after surgery, gets sort of a scar around it. That part needs to be changed and kept clean and things like that. But the pump itself can stay in place right in the right by the left ventricle of the heart for years and years. And it mechanically takes blood from the left ventricle and pumps it back to the rest of a patient's body. That's a more permanent fix for heart failure and cardiomyopathy. And like I said, there are patients that have been on heart pumps for years and years, and they have very good quality of life, and they go back to work and they can travel. Wow. Really, the only thing that they can't specifically do is go swimming or submerge in water and things like that. But they can take showers, and there's a special sort of protocol to prevent the drive line part from getting wet, which leads to infection. But patients can do very well on LVADs, and thousands of patients get that implant every year. Many patients, though, go on to heart transplant.
From after they've had
an LVAD. And so the LVAD can really temporize their heart from getting worse for many years.
Is that always the objective when they get an LVAD, to know that this is the end of the road before I need a heart transplant? Many
times it is. We sort of think about it in a couple different ways. So there's the patient that doesn't have an option for transplant and will never have an option for transplant.
Why wouldn't they have an option?
And primarily that is the reason is age.
Okay.
And so general cutoff, not always, general cutoff for heart transplant is an age of 70. And again, some programs differ, go up that, some are lower than that. But, kind of as a rule of thumb, age of 70 is a rough cutoff age for transplant. And so if you're 75, and remember we talked about earlier that heart failure is more prevalent in older adults.
Right.
If you're 75 and you're faced with advanced heart failure and cardiomyopathy, and, at that point you don't have an option for heart transplant, you have an option for LVAD. So that would be one of the primary reasons that patients would get an implant for an LVAD and not go on to heart transplant. Many patients do, though, go on to either decide that they want a transplant after they've recovered, or they have an implant of an LVAD knowing that they're getting a heart transplant at some point or hoping that they'll get a transplant at some point. They just got sicker as they were waiting for a heart transplant. I think our objective always is to keep as many options open for patients as we possibly can.
How long is the wait usually for a heart once you get on the waiting list?
It really depends, and it depends a lot on the area of the country. So if you're on the Eastern Seaboard, there are more patients generally on the Eastern Seaboard waiting for heart transplant. So the wait is generally longer. It depends on your blood type. Though a blood type O, which is the predominant blood type, there are more people on the list that are blood type O, so there's more competition on the list. A blood type A or a blood type AB doesn't wait as long. And it also depends a little bit on your size. So if you're a 6'5" man, who weighs 250 and is a blood type O, a heart from a 5'2" female isn't big enough. So you have a lot of the donors, wouldn't be a size that would be compatible with you. So it depends on a couple different things. Those are the basic ones. There are other things like anatomy and lung pressures, but those are really the ways that we sort of try to predict how long a patient may wait. But it can be years.
As a transplantation specialist, what does that exactly mean? What is your role in that process? Do you have to determine the criteria for a matching heart?
So many times, yes, but in a multidisciplinary way. So as a transplant cardiologist, we interact in a lot of different ways. One is we evaluate patients that we think would benefit most from heart transplant. We see them over time. We continue to see them as they're on the transplant list to make sure that they would still benefit from heart transplant and that when we minimize their risk of heart transplant. We're sort of constantly making sure that they'll be as successful as they can possibly be with heart transplant, that they don't have cancers, infections, that they're able to take their medications, all of those things. And we're constantly in touch with our surgical colleagues about how sick or not sick they may be, if they're progressing, if they're getting sicker while they're waiting for a transplant. And those are patients that may require an LVAD before they get a heart transplant. Sometimes they're more acute things that we can do as they're getting sicker waiting for transplant. So they're percutaneous LVADs that are more they don't last for long, but they can temporize a sick patient to move up on the transplant list to enable them to get a possibility for a donor sooner.
What does that mean, percutaneous? Is that the vest, the life vest?
No, the percutaneous LVAD is a heart pump, just like the implantable LVAD, but it can be done in a cath lab or even bedside sometimes in a patient that's getting sick quickly, that we don't have time to get them to the operating room for an implantable LVAD. Or we think that we can modify something quickly, sometimes it's fluid balance and things like that, as they have a temporary LVAD before they either get a heart transplant or get a more permanent LVAD.
And what kind of doctor is doing those kinds of procedures? Are they thoracic surgeons?
Many times they're the cardiothoracic surgeons. Our interventional cardiology colleagues can help us with that. So those are cardiologists that primarily work in the cath lab, but they also help us with patients that are in cardiogenic shock that need a quick percutaneous or quick device to help them come out of cardiogenic shock or improve their perfusion, their blood flow to their organs. So they help us quite a bit with that urgently in the cath lab.
So where does the life vest come into play? When is a patient recommended to wear one of those? So
the life vest is a vest, and literally it's a vest that a patient puts on under their shirt that's close to their skin, right against their skin. That is not so much for the pump function of their heart. It's to detect and treat an arrhythmia, which is an abnormal heart rhythm that could, if left untreated, could result in something called sudden cardiac death, which is primarily a rhythm called ventricular tachycardia.
Okay. So that's quite different?
So it's different. It's different than a heart pump, but it is something we use in patients that we think are at high risk for developing ventricular tachycardia that don't quite yet have criteria to have a defibrillator implanted.
Okay. Now, through this whole conversation, we've talked about the progression, starting with medications, more advanced therapies, surgery. When do you sit down and have that conversation with the patient about going on a heart transplant list? Is that your call, or is it a discussion that you have with the patient and you kind of come to together?
It's a discussion almost always we have together. So most of the time, you know the patient over trying to help them with their progressive heart failure. So you're counseling them and seeing them frequently regarding their medication management, their fluid management, their diet, their salt intake, their exercise tolerance. So you know them most of the time well enough to have the conversation of, I think you're getting sicker, you're not tolerating this medication, your blood pressure's lower, things of that sort. And you're preparing them for next steps. That being said, you really need to always be 1 or 2 steps ahead of where you think they might be. And I think that works well. So you're preparing that patient for what you might be thinking is down the road, whether that's in a month or 2 months or 2 years, what may be next steps. And I think that allows the patient not just to ask questions, educate themselves, understand what may be involved in something like a heart transplant, making sure they know that it's a multidisciplinary team that will be helping to take care of them, making sure they're able to tell their friends, their family about what they may be going through. And, there's a lot that goes into the evaluation for heart transplant. And it allows the patient to get ready for kind of a process of not just testing, but traveling, making sure that they have their insurance all together, make sure that they've got all their medications together, make sure that their health maintenance is up to date. So it can actually be quite a big process.
How do you go into a conversation like that and be hopeful rather than less of a resignation?
Yeah, I think in my experience, most patients are happy that we've had a conversation prior, letting them know that I think they're getting sicker and that I'm already thinking about next steps. And so when it comes to actually telling them I am going to start evaluating you for heart transplant, it doesn't come as a big surprise to them. And so it may be that I say something along the lines of, I think you're getting sicker. I think to be on the safe side, we should start this evaluation for heart transplant. During the evaluation, we may find something that we can change that actually makes you feel better for some time, but I also don't want to lose an opportunity to have this available for you, this heart transplant potential. And so I sort of have a conversation along those lines, so patients know that I don't think it's necessarily imminent that they need a transplant tomorrow, because that's not how we operate. But they know that I'm building sort of a safety net for a possibility around them. And so that's the most common way that I approach that. There's certainly patients that I don't know as well that come in really, really sick, and I don't have time to know them over time. And then the conversation can be a little tougher because they haven't been able to really process necessarily how sick they are, and it's more urgent. And, in some ways I approach it in a similar way, because I want to make sure that they know that we're keeping every opportunity, open for them, and that it's a challenge, but we are open and ready for a challenge. And we want to make sure, again, that every opportunity is open to that patient. And so, whereas it may be a little bit of a tougher conversation, I think most patients and families are sometimes even relieved that there's hope, that there's something else out there.
We are really short on time, but I have to ask this question because I think it's very fascinating, and I can't imagine people who are facing heart failure or advanced heart failure wouldn't have the same question. And that is, what is it like then for patients who have had a heart transplant once they come out of that surgery? Are you there with them? Do you tend to meet with them right away? And do they feel better, like immediately, minus the obvious surgery discomforts?
Yeah, I try to see them as quickly as I can after surgery. It always amazes me every single time. And I've been doing this for a while, but it's every single time, for the most part, they feel so much better so quickly. And you can physically see a difference.
Wow.
Even when they're still under anesthesia and have a breathing tube and things like that, many times you can see a physical difference right away.
Their color.
They've got good pulses in their feet. They're pink. They're not gray. Pretty much right away, their blood pressure's better. And for the most part, after kind of getting better from just the surgical procedure, many times people, for the most part, feel so much better right away, even though they know they need to do some hard work to recover and rehab and things like that. They also, many times, I get this quite a bit, they didn't sometimes even realize how sick they were, because many times it's so chronic that they've found workarounds for their dysfunction for so long.
Wow.
That they didn't realize how abnormal that behavior was.
Wow, that's poignant.
Yeah. It's really remarkable. I mean, that's why, I get up and come to work every day, because it always amazes me.
What's the most satisfying or the most gratifying part of your job?
I mean, that's it. I mean, just making people feel better. Yeah. I mean, even if it doesn't have to be a heart transplant, if you increase their Lasix by 20 milligrams or 40 milligrams, which really isn't that much, but they go from, barely able to walk around their house to, riding a bike in 2 weeks or doing whatever they feel like doing. I mean, that is so gratifying. Life-changing stuff. It really is. It really is.
Do you have a favorite patient's case?
I have so many favorite patients and cases, but while we were just talking, I was just remembering, I have this fantastic patient. She had a heart transplant a number of years ago, but I remember when I was seeing her before her heart transplant, and she was a young woman at the time, and she did okay for a number of years and then really developed bad heart failure. And when she came to see me after she had seen a couple different cardiologists, general cardiologists for her heart disease, and I would remember asking her kind of what activity does she do every day? What does she like to do? What's her exercise tolerance? That's really what you're asking. Can you walk up and down stairs? And she says, yeah, I can get up and down stairs. I said, okay, well, you're doing okay. The next time she comes in, I said, really? I mean, can you really go up and down stairs? And she said yes, and then I probed a little bit more, and I sort of figured out she was sitting on her butt, going up one stair at a time to do her laundry.
Oh, my goodness.
Every week, and it would take her the entire day to do one load of laundry. And, she was going up and down stairs. Right. She was. Chronic heart failure patients find workarounds to the point they think this is normal. Right. And so she could do her laundry. So if you just asked her, can you do your laundry? She would say yes, and she wasn't lying.
She just didn't realize how diminished her quality of life was.
Exactly right. Oh. So seeing that change overnight pretty much after she got her heart transplant, absolutely priceless.
Really makes you appreciate the things that we have and the health that we have.
Absolutely it does.
So my walk away or my takeaway from this is cut back on salt. Make sure that I get good sleep.
Yes.
Do a sleep study maybe.
I'm not quite sure we're doing their prophylactically sleep studies, but yeah, I mean, I think it's really important. I mean, the basics, if they're not controlled, can really end up turning into something way more significant like heart failure. So blood pressure, diabetes, salt intake, get your exercise, get your sleep, make sure you're watching these things. Right. As people age, they get, these things get more prevalent. So they really have to be checked quite frequently.
All good advice. Thank you so much, Dr. Feller, and thank you for all that you do.
Thank you so much. Good to be here.
We've been talking with Dr. Erika Feller at MedStar Union Memorial Hospital in Baltimore. Dr. Feller, thank you again for sharing your expertise here on MedStar Health DocTalk. For more information on advanced heart failure, go to MedStar Health's website, medstarhealth.org, or for an appointment with Dr. Feller, call 410-554-6550.